Today's topic is about ascending cholangitis, or also known as acute cholangitis. Before we study this topic, it is important to understand the functional anatomy of the hepatobiliary system, especially the gallbladder's location, function, and the ducts. In this diagram you can see the gallbladder, which is an intraperitoneal pear-shaped organ that is located in the right hypochondrium or the right upper quadrant of the abdomen. The gallbladder's primary function is to store bile. Many students are often confused with the function of gallbladder. They have this concept that gallbladder produces bile. This is wrong. Bile is produced by liver and is stored in the gallbladder. Remember this very clearly. How the bile enters the gallbladder for storage is important to understand. First, you need to understand that the biliary tree is a network of ducts that carries bile to the gallbladder, where it is stored after being produced by hepatocytes. In the liver parenchyma, we have the right and left hepatic ducts. These two ducts drain bile from the left and right lobes of the liver. Then, they join to form the common hepatic duct. If you were to see the gallbladder, you can see a duct coming out from the gallbladder. This is known as the cystic duct. When the cystic duct and common hepatic duct combine, they form the common bile duct. The common bile duct then enters the pancreas in the head of the pancreas and joins with the pancreatic duct and form the ampulla of Vater, which then opens into the descending part of the duodenum via the major duodenal papilla, which is controlled by the sphincter of Oddi. We have a brief understanding of the anatomy, so now let us look at the pathophysiology. When the ducts are obstructed by a gallstone, the flow of bile slows down or ceases completely when the biliary system is blocked. When the flow slows down, it thickens. Why? It is because when the flow slows down, the particles within it start to precipitate after spending too much time in the gallbladder. This precipitation of bile in the gallbladder is known as biliary sludge. Biliary sludge is an excellent growth medium for bacteria like E. coli, Klebsiella, and Enterococcus. You also need to remember that because blockage pressure also began to rise inside the biliary tract. This caused the bacteria to translocate into the bloodstream, leading to biliary sepsis. The greatest risk factor for developing ascending cholangitis are gallstone illness like Maritzi syndrome or cholelithiasis. The other risk factors are iatrogenic biliary damage. For example, during cholecystectomy or ERCP. Tumors like pancreatic, cholangiocarcinoma, and hepatic are another risk factors. There are many other risk factors than what is listed here. I have included a link for the complete causes. You can take a look later. However, in practical sense, you need to remember the common causes because common things occur commonly. Next, we will move to the typical signs and symptoms of ascending cholangitis. The commonest sign is fever, jaundice, and right upper quadrant abdominal pain. These cluster of sign is known as the CHARCOT'S triad. When the condition worsens, there might be signs of shock like tachycardia and hypotension. The patient's mental status also decreases. So when the Charcot triad is added with signs of shock and altered mental status, this is known as Raynaud's pentad. Besides these typical symptoms, patient might have signs of increased bilirubin in the bloodstream like itching, pale feces, black urine, nausea, and vomiting. Also, it is crucial to inquire about any recent biliary surgeries like ERCP and a history of gallstone disease. When coming to perform the clinical examination, you need to do a complete abdominal examination. You are typically looking for the signs of Charcot triad and Raynaud's pentad. Remember, if signs of peritonism like wooden hard abdomen is present, another diagnosis should be considered. There are a few diseases that mimics the signs and symptoms of ascending cholangitis. Diseases like hepatitis, liver abscess, Maritzi syndrome of pancreatitis, Gibson's syndrome and stomach ulcer. Ascending cholangitis can present with similar clinical features to other biliary conditions like biliary colic and cholecystitis. It is important for a doctor to recognize the differences in symptoms and signs of this different illness. Biliary colic, for example, is caused by impacted stone at the gallbladder's neck, which often manifests as cramping stomach pain in the absence of infectious symptoms such as fever or elevated inflammatory markers. In history-taking, it is important to find any connection between eating fatty foods and biliary colic. Consuming fatty foods frequently results in biliary colic. Cholecystitis, for instance, are manifested with the classic symptoms of persistent right upper quadrant discomfort, fever, and elevated inflammatory markers. Yet, because there is rarely a biliary blockage present, jaundice rarely develops. But this is an exception if the gallbladder is compressing the common bile duct, as in Maritzi syndrome. Next we go into the investigations. I have divided investigations into bedside, laboratory, and imaging. When comes to bedside investigations, ECG is a must. All patients who are seriously ill should undergo an ECG. The next important thing to consider is to take the blood gases. In ascending cholangitis, elevated lactate and metabolic acidosis may be seen. Next we go to laboratory studies. As a routine investigation, doctors often take full blood count. A higher than normal white cell count may indicate an infection. Raised levels of urea and creatinine in the urine can signify organ system malfunction. If you take the liver function test, you may observe elevated bilirubin, elevated ALP, or elevated GGT, which signifies an obstructive pattern. An elevated CRP is indicative of inflammation. You may also take coagulation profile to see for any abnormalities in the coagulation factors. Another test is amylase. If it is raised, this may be a sign of pancreatitis caused by stones. When comes to imaging, the simple and not expensive investigation is abdominal ultrasound. In abdominal ultrasound, a dilated common bile duct and gallstones may be visible. Other investigations include abdomen CT, MRCP and ERCP. Usually in hospitals, we often carry out transabdominal ultrasound to look for dilated ducts and stones, and then we proceed with an ERCP. ERCP involves cannulating the ampulla and inserting an endoscope into the second section of the duodenum. By removing stones or inserting stents, ERCP is both diagnostic and therapeutic. The likelihood of complications with ERCP is between 2 and 3%. Let us now go into the realm of treatment. For example, a patient is diagnosed with ascending cholangitis with sepsis-related complications. In this case, you must first treat the sepsis by appropriate treatment like the ABCDE principle. Often, this involves intravenous fluids, broad-spectrum antibiotics, and more oxygen. When possible, the sepsis 6 bundle should be initiated, and antibiotics should be given within an hour after presentation. Don't forget to take blood culture before initiating antibiotics. After you have settled the sepsis, it is time to remove the source of infection. Let's assume gallstone is the cause. In that case, ERCP, sphincterotomy, and drainage stent implantation is the standard treatment method. The sphincter of Oddi, which separates the biliary system from the duodenum, is cut during a sphincterotomy. This helps any common bile duct stones drain and flow through. If the patient is too ill for ERCP or if ERCP is unsuccessful, then a method called as percutaneous transhepatic cholangiography, PTC, and percutaneous transhepatic biliary drainage, PTBD, are the other options. However, in many hospitals in Malaysia, we are not having those options. The last resort of treatment is surgical biliary decompression. If surgical procedures are necessary, they are often carried out laparoscopic of their superior benefits and minimal side effects. Complications of ascending cholangitis can include acute pancreatitis, inadequate biliary drainage after surgery or endoscopy, and liver abscess. Surgical complications can include infection or bleeding, resulting harm to nearby structures like nerves and nearby vasculature. Here are some takeaway points for this disease. Gallstone disease, iatrogenic biliary damage and tumors are some of the causes of cholangitis. Fever, pain in the right upper quadrant, and jaundice are the CHARCOT'S triad of cholangitis symptoms. Rigors, hypotension, disorientation, and tachycardia are examples of symptoms indicating a systemic infection that may be present, and these clusters are called as Raynaud's pentad. A dilated common bile duct and trans-abdominal ultrasonography may indicate the presence of gallstones. ERCP is the investigative and management technique of choice.